Okay, well, good morning, everybody, and thank you so much for joining us today for the TRIA Sport Concussion Program presentation. Sorry for the delay, there was a little bit of a technical difficulty, but we are on now. Before I turn it over to Dr. Custer and Dr. Preszler, I thought I would read their bios for you just to learn a little bit more about our presenters today. So beginning with Dr. Preszler, Dr. Jonathan Preszler is a neuropsychologist and splits his time between TRIA Sport Concussion Program and Sanford Health. He completed his undergraduate studies at University of North Dakota and his PhD at Washington State University. After completing a predoctoral internship at Children's Minnesota, he completed a 2-year postdoctoral fellowship at University of Pittsburgh Medical Center Sport Concussion Program, where he completed both clinical work and research with mild traumatic brain injury. In addition to serving as a clinician for concussion and other neurocognitive injuries at both institutions, John keeps an ongoing research program. His research has focused on outcomes after concussion, particularly in the context of specialty care and multiple injuries, as well as factors complicating assessment or recovery, such as delayed onset of symptoms and parental factors. He has recently engaged in research of biomarkers of concussion and their interaction with other health-related factors, for example, BMI, and is particularly interested in developing more effective assessment in adult populations with mild traumatic brain injury. And then last but not least, Dr. Aimee Custer is a clinical sports neuropsychologist and serves as a clinical director of the TRIA Sport Concussion Program. She is fellowship trained through the University of Pittsburgh Medical Center, specializing in the treatment of sport concussion and post-concussion syndrome. She received her doctorate in clinical psychology from the Minnesota Professional School of Psychology at Argosy University after completing undergrad at the College of St. Benedict's. She studied rehabilitation and health psychology with a focus on spinal cord injury, brain injury, and polytrauma during her predoctoral internship at the University of Missouri. She has experience working with athletes across all levels, including youth, collegiate, professional, and Olympic, seeing now over 10,000 concussion patient visits in her career. She serves as a team neuropsychologist for the Minnesota Frost professional women's hockey and was previously retained for 3 years by the NHL for the players' concussion injury litigation. She is active in research, education, and program development, supervising students on a yearly basis and currently collaborating on several grant-funded studies. So Dr. Custer and Dr. Preszler, thank you so much for joining us and presenting today about the TRIA Sport Concussion Program. And just before you get started, just wanted to do a little plug for everybody attending today. Welcome, and just please enter your questions into the Q&A function at the top, and we will cover those at the very end. So without further ado, welcome. Thank you.
Thanks for having us.
Yeah, thanks so much. We're very excited to share our program with you today. John, you can advance to the next slide. So the TRIA Sport Concussion Program is an interdisciplinary program that specializes in getting athletes and individuals back to sport and an active lifestyle. Our full program is located at both Bloomington and Woodbury locations, and then we have other aspects of our program at different locations as well throughout the metro, including our performance center at Game Face. Our rehab services are also located at many of the TRIA PT locations throughout the metro, which really increases accessibility and location preferences for patients, which is very useful. We have immediate access into care for head injury and concussion through our orthopedic urgent care at our TRIA sites. And then we have access into our TRIA Sport Concussion Program within 1 week. Our entry point into the program is through our neuropsychologists. And our neuropsychologists act as a point guard for that patient as they progress through their treatment. So they're going to have multiple touch points with that patient as they go through their recovery process, and the neuropsychologist is guiding their referrals. So the neuropsychologist acts a little bit different in this program than we would be used to maybe seeing a general neuropsychologist function. And Dr. Preszler will cover that a little bit more in depth later in the presentation. But our active program and our treatment team also includes psychologists, physicians, physical therapists, and athletic trainers. We see as young as 5 years of age and up to 65. And again, are working with all different levels of sports or individuals trying to get back to an active lifestyle. So you don't have to be a part of a team or be injured on the field to be seen into our program. We also treat motor vehicle accidents, patients that may be injured in slip and falls, or workers' comp cases. We just want to ensure that that patient is correct for our treatment program and the tools that we have on site in our programs. If we screen a patient and they're not appropriate for our program, then we'll use one of our partners in the healthcare system, either through Park Nicollet or our Health Partners Neuroscience Center. So we have great access for brain injury care throughout our whole healthcare system. The TRIA Sport Concussion Program is very much focused on a team approach and making sure that we have excellent communication and educations for our patients. We want to make sure that we have communication not only between our providers, but all the stakeholders that may be involved in our patient care. And that could be coaches, that could be athletic trainers at their school nurses, employers. And we really want to make sure that we're educating our patients on the expectations of their recovery. This injury can be very scary, very anxiety provoking, and when patients don't know what those symptoms are coming from or why they're feeling a certain way, that can actually lead to a lot of complications. So education, handouts, and communication is very vital. In fact, one of the unique features of our program is having the athletic trainer navigator model. So that athletic trainer gets assigned to that patient case and it actually stays with them throughout their recovery journey, being able to go over, educational materials, schedule appointments, and again, communicate to other stakeholders for them. Most of our referrals into the program come from our orthopedic urgent care or our athletic trainers that are contracted through our high schools and colleges. But we also receive referrals from other specialty clinics in our network or out of network, emergency departments, urgency room, and then self-referrals. In fact, our program is one of the programs that brings in new patients into the healthcare system on a regular basis. We have a lot of treatments on site for our program, or again, throughout our healthcare network. And then we have some preferred referral sources that are independent practices that kind of contract or work with our program to ensure that we have all the treatments for these patients. On site, we have athletic training and sports medicine, exertion therapy, physical therapy for orthopedic and cervical concerns, vestibular rehab, ocular motor rehab, integrative medicine services, and behavioral health. It's really nice to be a part of a greater healthcare system because then we have access to neurooptometry, ophthalmology, neurology, cardiology, sleep medicine, chiropractic care, psychiatry, things that maybe not every patient needs, but when we do need them, we've got an excellent referral source. Additionally, too, we have speech and OT throughout our healthcare system that we utilize frequently. One of the unique features of our program is how our rehab is conducted through our physical therapy. And we get a lot of feedback from our patients that they love this aspect of their care. So our physical therapists and in our program are trained across multiple domains. They're orthopedic physical therapists that have specialty training in vestibular therapy, but also additional concussion rehab services. So when a patient goes into concussion rehab and PT, they can stay with that physical therapist as they progress through their treatments. So they may start out with ocular motor and cervical management and then progress into the vestibular rehab or into exertion. Again, our therapists are trained with cervical and post-traumatic headache management, ocular motor and vestibular rehabilitation, exertion therapy for autonomic retraining, sport-specific return to play, and additional dynamic movement or higher level vestibular, as well as dual task and cognitive overlay to ensure readiness to return to sport or any activity in life that may be more demanding. Another unique feature and a program that we utilize a lot, are so thankful that we have collaboration with, is our integrative medicine team that provides living well resources, stress management, sleep hygiene, additional treatments, meditation, pain education, acupuncture is housed in there. So this is a really nice treatment addition or complements a lot of our evidence-based treatments or active treatments that we're using. I can't speak highly enough of the behavioral health services and psychology that we have. We have a specific provider on our team, Dr. Sikorsky, that provides biofeedback, talk therapy, more acute trauma, injury-related focused treatments that have been vital for our patients' recovery. We also frequently utilize our sports nutritionists, our pain program, and our spine specialists on site at TRIA. And next slide.
Oh, sorry. Apologies.
No, that's okay. Couple more fun facts about our program. So we're the only sports neuropsychology-led concussion program in the state of Minnesota. We are going to clear over 2,500 concussion patient visits this year. And the furthest distance we've had a patient travel to our program is from New Mexico. The furthest distance we've reached virtually, and this was during COVID, was Berlin, Germany. We had presence at the International Consensus Conference, which is the international meeting that determines best practice for care, and it meets every 4 years. So we had presence at the 2021 conference. Our program also focuses a lot on education research. We'll hear more about that as well as providing supervision to students. We provide quarterly internal education, including grand rounds and journal clubs. Throughout my 10 years here, I've had many students, residents, fellows that have followed me or have come through the program for training, which has been really neat to have and have all their different perspectives, which have included PM&R, OT, athletic trainers, and psychology students. We have a goal as a program to have 5 or more professional presentations per year, and I think we're on track to get 10 this year, so which is great. We're a frequent source for local media and news outlets, and also are highly involved in our marketing as well through TRIA. And John, I'll turn it over to you then.
Sure. I just wanted to briefly touch on what neuropsychology is. Often people, or we use that term a lot around here because we are, like Aimee said, the point guards, and it's not the most common of subspecialties. And so what neuropsychology broadly is the study of brain behavior relationships. That can be anything behaviorally related, but we also include behavior, or historically it's included behavior broadly defined. So meaning emotional functioning as well as a part of that, but also neurocognitive abilities are often a heavy focus of neuropsychology. Someone's attention, memory, reasoning skills, things like that. But even things like sensation, motivation, anything that is sort of a daily life manifestation of the way the brain is working. Clinical neuropsychology, then, just in the clinical realm, is really the application of that, of those studies to how a patient is doing in front of us, how different brain-related dysfunction is causing difficulties in their daily life, or not causing difficulties in daily life in terms of their strengths. Historically, TBI is a really strong, broadly speaking, not just mild TBI or moderate TBI or concussion, but even severe TBI is something that neuropsychology has really had a strong presence in. Nowadays, there's also a strong presence in things like Alzheimer's and other neurodegenerative processes. For our purposes, we're really focused on the approach of neuropsychology in terms of understanding the effects of mild and moderate traumatic brain injury, or sometimes called concussion. The specialty of clinical sports neuropsychology is even more subspecialized, and within that, it's really focused, like I mentioned, on mild, sometimes moderate TBI in sports and athletes. And like Aimee was getting at, I think most concussion clinics that have neuropsychology staff aren't just dealing necessarily with sort of your high school athletes, college athletes, although that's going to probably be a plurality, if not majority, of the patients. But we're also working a lot with patients who are adults and still living an active lifestyle. There's a specific guidelines, both they're called the Houston Conference Guidelines. That's a broader guideline neuropsychologically. And then there's also more specific guidelines established by societies in the neuropsychology field. Some most popular of which is the Sports Neuropsych Society. And the focus of the sports neuropsychologist is really to look at those brain behavior relationships, that cognitive, the social, emotional, sensory, behavioral, all of those factors in the context or after someone sustained a brain injury. After the initial assessment or looking at how those factors or how that brain injury is affecting those different skills or functioning, then typically what we're doing, or what a sports neuropsychologist is doing, is guiding treatment and helping sort of facilitate a quick recovery or the greatest recovery possible. It's also a big role for sports neuropsychology in advocacy in terms of like safe participation in sports. That's both in returning to play, but also prevention. And so there's been a really strong role for neuropsychology in that domain. Sometimes that advocacy can be outside of the clinical realm, but sometimes it can be with the individual patient as well. Often in day-to-day life, what a clinical sports neuropsychologist is doing is interpreting the most often computerized neurocognitive tests, although sometimes those are neurocognitive tests that aren't administered by a computer as well. And typically when we're seeing a patient come in, we're often doing a very focused evaluation to look at not just their neurocognitive abilities, but also ocular motor, the way their eyes are working after an injury, which are often dysfunctional after a concussion, or looking at vestibular or balance deficits. In addition to that, we're looking at behavioral, sleep, emotional, those domains to see how those might be impacting either the trajectory or how they might be even primary parts of a concussion injury as well, and managing that. After doing some of this initial evaluation to see, in those domains where the dysfunction lies, or how they're interacting, we're often providing the patient and parents, if they're present, with clinical trajectories, treatments, as well. A big part of what we're doing is determining what is the appropriate rehabilitative program for a given patient. Because there's so many different domains, and Aimee will talk a little bit more about that, but 5 or 6 domains, we'll talk about 6 today. I think that's where we kind of fall. It kind of depends on the research group you ask, but I think 6 is kind of where the field is coalescing, because there's these kind of 6 different domains where a concussion can really impact a patient. What our essential part of our role is to determine how to best rehabilitate those the domains that are weak or are impacted by the traumatic brain injury or the concussion. Typically, we're also going to talk a bit about sort of what's our expectation for recovery, what's the trajectory going to look like for the patient, and then especially for those high school athletes and the adults, we're talking a lot about how to best approach work in school. Often that's twofold. One, providing some accommodations to make sure that a kid doesn't unnecessarily fall behind, or a adult doesn't necessarily sort of get demerits, so to speak, at work, but also using work and using school as a rehabilitative activity. There's some good research updates that have happened in the past 5-10 years that have allowed us to sort of navigate that in a way that can facilitate the best recovery for a patient as well. And then a huge, probably the most important part of our role in terms of the stakes is deciding when a patient is ready to go back to play, contact activity in particular, whether they're an adult or a high school football athlete, deciding when, they're cleared, they're no longer at a strong increased risk here for secondary effects if they were to hit their head again. There's a really sort of a strong part of our program and the programs that we trained at as well in dealing with very complex cases. We'll certainly see sort of more run-of-the-mill simple cases as well, but most often when there's a really complex case and of one of our referral sources, they'll send that our way. And Aimee will take it over from here.
Yeah, thank you. I have joked, even when I started with the program back in 2015, it was like a sport concussion program. I almost feel like we need to revise it to a post-concussion sport, just because of how just this injury has been managed and changed. And a lot of those more simple cases are very well managed, with athletic trainers in the field or through teams. And so we are seeing more of these persistent, more complex cases that might not be recovering as we would anticipate, in that typical 10 to 14 days. Just to expand a little bit further about what an office visit would look like when someone comes in to see us. And so that first visit, as they come in, they may be with us for an hour to 2 hours, actually, as they go through a pretty extensive assessment, initially working with the athletic trainer, getting that clinical interview, and undergoing some symptom scales or administration of some neurocognitive testing, which is always expanded further on with the neuropsychologist. Those symptom scales are looking beyond just concussion symptoms, but also mood measures. They may have more specific cognitive or visual assessments as well. Neurocognitive testing, right now, we're utilizing the computerized impact platform, but we also will soon have access to Sway. And then again, a very individualized approach when we use different paper and pencil batteries for these patients. But during that initial visit, everyone will go under some type of neurocognitive testing to help inform their treatment plan. They'll also undergo visual, vestibular, ocular, motor, and balance assessments. For those patients that are traveling some distance to our program, or maybe are out of state, they will also have a same-day physical therapy assessment that will look at more higher level vestibular or different aspects of vestibular, some movement and exertion, and then we'll have a case conference to come up with that individualized plan for patients. On the right here is just an example of a handout. Again, we really advocate for having handouts and information to patients so that they clearly have expectations of where they're going on in their recovery journey, and making sure that they feel that they're in the driver's seat as well, that they're not just kind of passively waiting for this injury to go away, but that they can actively do something. And so this is our stepwise return to play guidelines, something again that the athletic trainer on their case is going to ensure that they go over with this and be communicating with their providers. So when they have when patients have different touch points with our providers, they may then get advanced through some of these recovery stages. It's not that they're waiting to just come back and see the neuropsychologist in 2 weeks to get their advancements, but they may be getting advancements with other providers through the program, which is really nice. And go on to the next slide. So this provides a little bit of a framework, perhaps, of how we look at cases. There's this kind of joke of once you've seen one concussion, you've seen one concussion. And at TRIA, we really take pride in making sure we're utilizing evidence-based treatments, but also creating an individualized approach for care. And the literature provides us with different risk factors or characteristics that patients may have that could lead to these protracted cases, but really also understanding personality characteristics, their goals of where they're trying to get to through this recovery. All these different individualized characteristics play a role in how that treatment's going to be applied, but also of how this injury may play out. Of course, there's different concussion factors, different force vectors, the impact, how safe did the individual feel after an injury, what were their immediate symptoms. All of these things play a role in not only our assessment, but then also the recovery process. And again, as John mentioned, we're looking at, these are the 6 kind of main profiles that the model that came out of UPMC. And our job is to figure out what is the primary, secondary, and tertiary areas of dysfunction. What's our best point of intervention? And that may change actually as they go through their recovery. And sometimes it's a little bit hard to know where there may be an overlap as well. I'll have you advance to the next slide. When we don't know what to do, which is rare because we always know what to do, right, John?
Yeah. That's right.
Right, exactly, always. But again, this is the model that comes out of UPMC, and where they've really honed in on matching targeted active treatments. And although this is getting a little bit outdated, or when it was published in 2017 here, but it really holds true. And what they have found is that exercise is a very effective treatment application for any type of these trajectories. Now, we don't see it underneath the ocular profile. That's because it's not directly treating it, but it would still have secondary benefits for those patients to be active. In fact, those that just have an ocular profile occurring, they are usually asymptomatic with exercise. But we can utilize exercise as an effective treatment for these trajectories, such as cognitive fatigue, anxiety or mood, post-traumatic migraine. And that's one of the areas of education that we consistently do, and I still see. Less and less do I see patients coming in that are still excessively resting or in cocoon therapy, which is very old school thought. But really educating patients that it is safe to have symptoms, especially once you get out of that subacute phase, to be interactive and to be doing things for that reconditioning. Obviously, we want to make sure they're safe and they're not going to be re-injured. But utilization of exercise has been vital for our program. Next slide. I'm not going to go through each one of these, but again, as John mentioned, kind of 6 or 7 different types of trajectories. These are kind of the main areas of focus, those words in bold, those areas where our patients are coming in for persistent symptoms. Again, our program we can see patients same day injury, actually, which is kind of rare, but every now and again it occurs. But then we can also have people entering our program that are years post injury. And so underneath each one of these categories, I've just listed some of the evidence-based treatments that we will apply. These don't include some of the complementary alternative treatments also that we've utilized or may be appropriate in these cases as well. And John, I'll hand over to you.
Yeah, so I just wanted to go through a case example here. This was a case I just saw a couple months ago of a freestyle skier. This was a 18-year-old male competitive freestyle snow skier. So in my mind, the word that comes to mind is does tricks. I don't know much about skiing. I like to ski, but I don't really know anything competitively about it. And he had a bad trick or bad fall when attempting some sort of combination of flipping and spinning, and hit the back of his head. No loss of consciousness for this kiddo, but he still was pretty immediately disoriented. Had a lot of signs of the injury that we often see. Excuse me. So for him, he had followed a standard protocol related to the school and competition related by his sport protocol for about 3 weeks, but just wasn't, had some initial improvement, but otherwise wasn't getting much better. So he presented to us 24 days post-injury, still complaining of some fogginess, dizziness, headaches, blurry vision as well. Our initial evaluation that we put him through on that 24 days post-injury was notable for some neurocognitively slowed reaction time, some objective ocular motor abnormalities, and I'll stay away from any kind of the terminology, but essentially his eyes were not working together in a way that we often see after a concussion. He's also had some vestibular sensitivity. I often tell patients that's the brain's ability to sort of interpret movement and motion. He was very sensitive to a lot of visual motion in his environment. Also put off his sort of balance or sense of awareness of where he was in space, which was pretty disruptive of his ability to maintain his high level tricks that he was doing on a regular basis. He also had very high anxiety. He was very, very concerned about these symptoms, especially as it related to returning to his sport. So what we put him through was a treatment course that included primarily physical therapy for this kid. We followed him for about 3 weeks, received physical therapy, and the physical therapy did 2 things with him. One, included that vestibular, and it included the ocular motor rehabilitative activities. So we have good rehab sort of exercises for both of those domains now. And sometimes we need to include higher level of care than than a physical therapist. But in our case, one of our in-house physical therapists was able to work with him and use some of the exercises that we know, or the rehabilitative activities that we know, to get his ocular motor functioning and his vestibular sensitivity back to sort of normal levels, at least in sort of day-to-day functioning. But for him, he had a very, very high level of athletic ability, particularly with regard to his balance, his ability to have a good awareness in space and movement in space as well. And so we had to be pretty careful with our progression back to full competitive freestyle skiing, because often what can happen is the last symptoms to go away are those that occur at the highest level of movement, especially for someone with vestibular ocular motor issues. And so as we're trying to progress him to make sure none of these symptoms are there, or as well as rehab those symptoms, we also don't want to put him at risk for having another injury. And so our last week, especially week 10 days of treatment, was really getting him to a place where he could return to these higher level activities in a safe manner, but also in a rehabilitative manner. So if any symptoms did come up, we could target those. So often that included, especially with the physical therapist, in coordination with the physical therapist, I should say, prescribed progression of his tricks, of the activities he was doing beforehand, in a safe manner, as well as included exercise, as Dr. Custer was talking about, as Aimee was talking about. So after this, he was cleared competition after three and a half technically weeks, after we had initially seen him, after that 24 days that he had presented to us. And successful completion of PT. For him, he was still fairly anxious at the time of clearance, just about the potential of symptoms returning as he got back to competition. And so we had to put him through some sort of simulated competitions, and then we actually had him follow up one last time by telemedicine while he was at a competition to ensure that he was still feeling well as he went to that highest level, especially because there's a little bit more adrenaline there, and we'd like to make sure that there's no sort of symptoms that come up with that, or any symptoms that do, or we don't believe are related to the injury itself. And just as noted in that second to last bullet point, at clearance, everything was looking back to normal. He no longer had any of that oculomotor vestibular sensitivities. Neurocognitive scores had normalized, so we had the nice objective findings that we were looking for. And I'll hand over to Aimee to go through one of her cases.
I'm going to just briefly touch point on two different cases just to highlight again some of the differences of patients that we see. I also just want to be mindful of time, so I'm going to kind of speed through these a little bit, but this case that just recently happened not too long ago, and it was just a really neat experience. We had a 60-year-old physician who had a syncopal episode and was referred in by one of our neurologists, who was still dealing with fogginess and dizziness and blurred vision, and really having a hard time with movements, very fearful to get back into exercise, obviously has not been able to get back into work. And so we see him, 1 week post, he's been resting, and of course getting very anxious that these things aren't getting better. So we did our full assessment and workup, and we see a couple things objectively, most notably some challenges with smooth pursuits or tracking, some stuff that might be suggestive of positional vertigo or peripheral vestibular dysfunction. And so we got him into PT same day. Did a full evaluation, and he was positive for BPPV. We got a treatment involved. He followed up 2 days later, and the athletic trainer on his case was in communication with him on a daily basis, and we were able to actually update his work letter. When I first saw him and he left to go to the PT visit, I was, you might be out of work for another 1 to 2 weeks. I don't know. I'm not sure if this is peripheral versus central vestibular and how this is going to go. Everything cleared up really nicely, and he was able to return to work in 3 days. So huge impact on his life. Another case example for me, I have a 20-year-old male who has a history of ADHD, dysgraphia, anxiety, depression, and then protracted complicated recoveries from multiple previous concussions, and still dealing with a pretty significant bike accident injury from 2023, but then had these subsequent injuries after. He moved home from college after he failed out of multiple college courses and was having very limited success with physical therapy. So he began doing extensive rest and avoiding activity. This is one of these cases that, this patient may be with me, unlike the physician who I see once or twice, but I've worked with this patient now for, I think, over a year, and we've had great success in his case, but we've used a lot of different approaches for him, and a lot of it came from education on how to actively get back into getting over the fearfulness of having those symptoms actually provoked during his recovery. Following this expose, recover model and reconditioning, he's involved in multiple treatments through concussion PT, but also working with our neurobehavioral optometrist, and having to address some of the premorbid ocular motor components that were actually exacerbated by concussion, and these benefiting greatly from vision therapy and corrective lenses, but also supplementing with biofeedback and behavioral health medications and supplements. And things are looking good. I think we're going to be able to get him back into college, but it has been quite a journey for him and his family through this. Go ahead now.
Yeah, and so I'll very briefly just go through some of the research. As mentioned previously, I still kind of keep an active research program, and one of the recent publications we were able to get into the Journal of Neurotrauma was a study investigating 10 to 21-year-olds who had sustained 2 or 3 concussions. And all of these 10 to 21-year-olds had received specialty care as our program provides. And after each injury, so that specialty care might have included any sort of the combination of therapies that or treatment procedures that we use that Aimee was talking about previously, but all were fully clear, just meaning that objective signs were either absent or consistent with their baseline functioning, and they'd return to play without any, or return to previous activity without any recurrent symptoms. What we found with these 200 or so athletes and non-athletes is that at each subsequent injury, so for those who only had 2 at the next injury, and for those who had 3 at the next 2 injuries, they recovered an average of 4 days faster and had slightly less severe, 2 less symptom point scores, significant but small difference. But that big finding is they recovered an average of 4 days faster at each subsequent injury. It also presented an average of a half day faster to clinic at each subsequent injury. So 1 full day by the 3rd injury for those who sustained 3. And so what we're finding here is that with sort of the specialty care model, often it can mitigate the risk for having some sort of compounding effect from each injury. The kick of it is that last bullet point that I just put up is those who had really long recoveries in the first injury, we're talking about months long recoveries, they actually had more improvement at subsequent injuries. They had this effect, they experienced this effect to a much more significant degree. So it wasn't as though there was some subset of people who had protracted recoveries at each one and kept getting worse and worse and worse. Those who we think might be at risk for having longer recoveries at each subsequent injury actually were experiencing even more of a reduction in their days to recovery at injuries 2 and 3. What we're thinking in terms of why this might be the case, one, patients might just feel more comfortable and know how to approach it. That could be part of it, although the treatment that is appropriate for each patient changes even across the injuries, so that might only count for a little bit of it. There's also good reason to believe that presenting to the clinic earlier at each injury leads to quicker recovery. There's 2 or 3 studies that have shown the quicker to specialty care that one presents, the faster they recover. And then there was a third. Oh, no, excuse me. Those are just the only 2. So those were the 2 kind of things that we're thinking might be accounting for some of that effect. I'll turn it over, the research part, over to Aimee now.
Thank you. So I'll just briefly cover, we've got 2 actual grant-funded studies that are underway right now. The first one is personalized accelerated theta burst transcranial magnetic stimulation, or TMS, in mild traumatic brain injury that we're recruiting for right now. In fact, both studies, I believe, are in recruitment. The other one is repurposing insulin with intranasal administration to improve function after mild traumatic brain injury. I'm also in collaboration working on a grant proposal with University of Minnesota, and then also through TRIA, we just submitted a grant as well. Both of them are looking at, again, different types of treatment approaches and rehab for brain injury. So very active year for sure with research and education for us as a program as well. So I just want to be mindful of time. I think there may be something else in regards to some research at this point, but I'll turn that over and then we can get to the Q&A unless there's anything else.
No, nothing from me.
Okay.
Well, Dr. Custer and Dr. Preszler, thank you so much for your absolutely amazing presentation today. And similar to what Dr. Custer was saying, before we enter Q&A, I just wanted to say one little plug regarding some of the research that their teams are conducting by saying that as a closing note, at Health Partners, we are dedicated to continued improvement in patient care. Our Health Partners Institute is currently working on a clinical trial to treat mild traumatic brain injuries like concussions with intranasal insulin. We are currently raising funds to support this study, so please reach out to the foundation, Park-Nicollet Foundation, if you would like to have more information about that study and developments on that. And with that being said, I will look and see what Q&A we have here. One of our first questions is, why is there an age limit of 65 for your patient? Excuse me.
Yeah, I don't like any older. No, I'm kidding. We will see beyond with that as well, but it's just usually a special request. A lot of that has to do with just a cutoff limit of like we don't have access to CT, head CT. So when we get a little bit older, we've got a higher risk with some of those slips and falls, or for them to maybe be on blood thinning medications. And so we want to make sure that we're getting them to urgent care or emergent care if needed. And then again, to just some of the treatment modality, they may be better served in some of our other locations or other TBI clinics if we need certain types. So again, if they're very active, I've worked with patients up to 75 in our program here. But again, it's just a little bit more of a special request that comes in.
Thank you.
Mm-hmm.
And then we have another question here. Let me see here. I'm just trying to expand it. Okay. We do have a participant that said, I'm a retired psychiatrist who saw many patients with TBI and sports injury, and I'm delighted to see this excellent program. Let me see here. Never mind. You answered that question. Excuse me. So another question is, the use of guardian caps in professional football has become more prevalent. Do you think these should be more widely used across the sport and across all ages?
John, do you want to go or do you want me to?
Sure. Yeah, no, I can
both
take
do
this
it.
one.
Sure.
Guardian caps are one of the few things that might help. When I've seen NFL presented data, it does seem to have a lower incidence of head injury. However, I've recently learned actually that the Guardian caps that are manufactured for the NFL are different than the Guardian caps, same company, but a different model. And we don't know what the difference is than those that are sold to the general public. On top of that, there is one college program that I'm aware of that found actually initial increase incidence of concussion when they used the guardian caps during practice. The main concern there was potentially some recklessness, some invincibility sensation or feeling from the players. So I would say it's probably a little premature. I'd love to see some sort of publicly available and ideally third-party validated or investigated data that shows that the guardian caps are really effective before something like that is implemented sort of more broadly or as any kind of policy. But I do remain open-minded that they could be helpful if I could see that data, if that data comes out.
Thank you. And just one final question that I wanted to ask you, just to be respectful of your time, is with the over 2,500 related concussion visits that you've seen with patients this year, are there any common sports that sports that patients participate in that are presenting with concussions that you're seeing from a trend perspective?
Yeah, we do. I mean, we see as a program, possibly because of some of the contracted programs and other affiliations we have, but we do have a high rate of hockey for sure. That's a little bit, that exceeds us a little bit than compared to football. Again, but I think that's just a little bit of the contracts that are going on with CARE. We also see a high rate soccer, lacrosse. And then I also actually see pretty high for some cheer and gymnastics, things that you might not think of, as like a contact sport. As well. Yeah.
That's fascinating. Thank you for sharing that. Let me see. Let me just double check here. See if we have any more questions. Yes. It feels daunting that there is so much risk for concussion. Do you have any tips for how to best protect our young athletes?
Mouth guards, probably the best tool you can use. Mouth guards, there's some evidence that neck strengthening can help as well. that, especially in very specific types of hits, head-on hits, some neck strengthening can help. Is there anything else, Aimee, that I'm missing there that you regularly?
When we think about, like, again, I think that we've got limited evidence about some of these wearables. And really where it lies is I think they're investigating and looking at, and hopefully there is something, but I think it really does come down to like smart play and having proper tackles and ensuring that, that kids are playing safe, for this. I also educate my patients on, just having awareness of things that they can control. When our athletes are more stressed, when they have a lack of sleep, when they're ill, you're going to be at greater risk for injury. So we want to make sure we're setting them up for best success. There's even research that looks at how hydrated somebody is and how effective that, or how impactful that injury could be. So, and then I think too, just really making sure that there's good education awareness that, this is a serious injury. We've got to, it's something that we can treat. It's not something that should be feared, but it's something that should be brought up, spoken up about, and treated. And, if we treat these properly, we see that athletes are able to get back to, and we see such huge benefits of sports that outweigh, some of these risks that could possibly be linked to concussion. So it's a great question because we want to keep sports alive. We want to keep kids active and safe. I just don't know if we're there to say wear this certain thing and it's going to protect you. We just want to make sure they've got the right mindset and that we're supporting them correctly.
Yeah, the only other two things I'll add is there's some potential for a few supplements that may be helpful in preventing the severity of the injury and the duration. There needs to be more research on those, but the rodent models in particular are pretty hopeful. And then, like Aimee was saying, maybe the best thing you can do is be sure to remove an athlete after a suspected injury. One of the effects in the research that's really robust is for every minute you stay in play, even if you don't sustain another head injury, every minute you stay in play, that increased neurometabolic demand on the brain really does worsen the severity and the severity of the injury and the duration of the recovery, but between 1 and 3 days per minute you stay in, depending on the research study. And so getting someone removed and then getting it treated really effectively before sending them back to play. I know it's not preventative, but it's at least preventative of sort of a longer recovery or at least to some degree cumulative effects that could occur.
Thank you both. And thank you for your valuable recommendations and insight. And I just wanted to thank you both for taking the time out of your busy schedules to present to us today about the amazing work you guys are doing for local athletes, and I should say also domestic and international athletes as well. And just if we have any other questions come through after the session, is it okay if I forward them your way via email?
Absolutely.
Yeah.
Wonderful.
Yeah.
Well, thank you both. Thank you everybody for attending and have a great day.
Thank you.
Thank you.
Thank you.